प्रवीण ने भेजा, सॉरी डॉक्टर राजेश।
हाँ, जिसने भी भेजा है, बिकॉज ये फिर हैंग हो जाता है, बहुत टाइम लगेगा, और एक बार कंप्यूटर हैंग हो गया ना, सब हैंग हो जाता है, बस हो ही गया।
So this is coming live on YouTube right now. I mean, I started that. Whenever you want me to, remove this slide, I'll do that. Huh?
Remove what?
The present slide which is coming here. I mean the banner which is
remain. This could remain. Dr. Sabanti is going to start the meeting.
Okay.
And then I'll take over. आप मुझे बस वो डॉक्टर राजेश मेहता वाला ना, वो बायो जो आपने पीपीटी भेजा, वही टेक्स्ट ना मुझे इस पे भेज दो ईमेल कर। मेरा कुछ नहीं खुल रहा है अभी, डॉक्यूमेंट भी नहीं खुल रहा।
मेल बॉडी पे भेज दो ना।
हाँ
ओके, उन्होंने काफी बड़ा दिया हुआ है, उसको छोटा कर लेना।
एग्जैक्टली। कोरियस
Vishal, can we see all the participants in the list?
Praveen, you are saying something. Which list you are talking about?
मैं पूछा था सभी पार्टिसिपेंट्स को हम क्या इस लिस्ट में देख पाएंगे?
वो जो अटेंड करेंगे उनको अटेंडीज वाले उसमें देख पाएंगे, और जो जो हमारे पैनलिस्ट और स्पीकर्स हैं वो पैनलिस्ट और स्पीकर्स वाले साइड में। तो आई मीन अगर आप अपनी स्क्रीन पे आप पार्टिसिपेंट्स को क्लिक करोगे so it will show you two separate lists, one for panelists, another for attendees. आप क्लिक कर रहे हैं?
Good afternoon. Am I audible now, Vishal?
Yes, ma'am.
Yes, Dr. Sevanthi, you are audible.
Oh,
Now you are audible.
I had to do a shutdown and join back. I was so
Technology can be very frustrating.
But no problem. Dr. Devji is there. Good afternoon, Dr. Devji.
Good afternoon, Devji. How are you?
He's on phone, I believe.
It seems so. He is on mute.
I think I'm going to rejoin too because my laptop is getting so slow.
We still have 9 minutes, Novina. So if you want, you can rejoin. Otherwise, I mean, I can see. I mean, it's absolutely fine. I mean, you're audible.
Yeah. No, yeah. It's really scary when the laptops become slow just before the meeting.
Hi Vishal, are you able to hear me?
Thomas.
Yes, Dr. Devji, how are you?
Good.
Good afternoon, Devji. How are you?
Good afternoon. आप कैसे हैं? How are you?
Chiku, thank you for all your kind wishes. Better.
Good. Nice to see you.
Hello, Dr. Devji. I'm Novina from We Collaborate for Nutrition.
Hi, Navina.
Hello, Dr. Devaji. How are you?
Hello, sir. How are you?
I'm good. Thank you. Welcome. Good afternoon, Dr. Sevanthi.
Good afternoon.
Hi Vishal, Rajiv here. Can you hear me?
Yeah, good afternoon, Rajiv. I can very much hear you.
Okay,
Yeah.
great.
Thank you so much for joining, Rajiv.
Thank you.
Welcome, Rajiv. This is Praveen from Alive and Thrive.
Hi Praveen, hi. Thank you. Thank you for inviting me to this.
Thank you for joining.
Good afternoon, Rajiv.
Hi.
Glad that you could make it.
No. So of course.
Good afternoon, Dr. Rajiv. I'm Novina from WeCan. We collaborate for nutrition.
Hi, Dr. Navina.
Hi.
Nice to meet you. Okay, let me
Yeah.
put my video on, otherwise.
Yes, it'll be good to have the faces on.
Yes. Here I am. So, good.
Hello, good afternoon, everyone. This is Sharika from the World Food Program.
Hi, Sharika. Novina here.
Hi, Navina. Good to see you.
Same here. I don't get to see you though. Can we also have the privilege of seeing you?
Sure, I'll just switch on my computer in a bit. Yeah.
Yeah, sure.
Hi, Sharika. Happy that
Hi,
you
good afternoon.
could join.
No, my pleasure. Absolutely.
Hi, Sanjeev. Thank you so much joining in the early hours of the morning. Can you hear us? Hi, Dr. Sujit.
Hello, Dr. Sujit.
Yeah, hi, good afternoon.
Good afternoon.
Thank you for joining in.
My pleasure, always.
Very good afternoon, Dr. Mehta. Very thankful that you could join us.
Good afternoon, Sevanti. How are you?
I'm good. How about you, sir? And so happy that you could join us today.
No, good effort. As much as possible, we should push quality. This is the of quality. So,
good afternoon, sir, and welcome. Praveen here.
Hi, Praveen. So, listen, I would have to leave at around 2:30 because there is an interview panel where I have to participate. So I hope by then my work will be over.
Okay, we would have liked you to stay throughout, but since you have another meeting, it's fine.
I couldn't refuse this. This was a interview panel where I.
Good afternoon, Dr. Rajesh. Thank you for joining in.
Yeah, very good afternoon, Dr. Sebanti, and good afternoon to everyone.
Good afternoon, Rajesh. Good afternoon, Dr. Sujit.
Good afternoon. Good afternoon, Mr. Praveen.
Good afternoon, Dr. Sharika. This is Praveen from Alive and Thrive.
Hey, good afternoon, Praveen. Good afternoon, Dr. Mehta. So good to see you.
Minnie, we can't hear you. You seem to be muted.
Hello. I think there is some setting issue over there. It is rectified.
Now we can hear you and see you.
Yes, yes.
Thank you for joining in.
Thank Hello, you. everybody. Hi, I'm here.
Good afternoon, Veenu.
Hi.
Hi, Veenu.
Hi, Dr. Banti. Hello, Minnie.
I think we should start in
Yes.
a little bit. I think let Alok. Sanjeev seemed to have joined, but
I'm here. Sebanti, I'm here.
oh, thank you so much, Sanjeev, for getting up at 4 in the morning.
That's not a problem. Delighted.
Very glad that you joined. Hi, Robert. Thank you for joining in. Is Alok around?
Hello.
Dr. Alok just joined.
Yeah, Dr. Alok has also joined.
Okay.
Good morning. Good afternoon.
Hi, Alok.
Hi, Sevanti. How are you?
I'm good. Happy that you all could join. Good to see you after a long time.
Same over here. Wouldn't have missed this for anything.
No.
Hi, Alok. Good afternoon, new look.
Hi, Praveen. How are you?
I'm good, thank you.
That's the only benefit of lockdown, right?
Yes.
You can keep trying new looks.
Yeah.
Hello, Alok.
Let me know. I think in another 5 minutes we can start, I think. Thomas isn't around as yet.
Thomas is not there yet.
Hi everyone. I mean, Thomas is trying to join. I think there are some technical glitches, so please don't wait. I mean, he'll be joining anytime soon.
So I think we can start, Dr. Sebanti.
So let's start then, if everyone agrees. Is it okay? We start now?
Yes, Dr. Sebanti, I think we should start. It's already
okay. Okay. A very good afternoon and warm welcome to all of you to this workshop on quality of nutrition service delivery and use of data to improve quality. We are very thankful and very encouraged by seeing the response that we receive from all of you, and that reflects that we all recognize that to improve nutrition outcomes, it is important, while we talk about coverage, we need to make the coverage effective, and that's why we need to talk about quality. And this workshop actually aims to start that journey of learning and engaging and making a difference on ground for quality improvements in nutrition service delivery. It's like a beginning of a movement. We talk about the Jan Andolan for nutrition, but this is the movement for quality in nutrition programming. And so very glad that all of you could make it. Our special thanks from this team of Alive and Thrive, IP Global, WeCan, and the National Data Quality Forum, who have come together to host this workshop. We welcome and thank our esteemed speakers who have joined us and have managed to find time despite busy schedule. And we are thankful to the panelists, the discussants who would be sharing their insights with us. And yes, to all of you, the participants with whom we will start our journey of mutual learning and sharing to prioritize quality and make it a reality in nutrition programming. So without any further words, I would request Navina to take you through this workshop. Navina, over to you.
Good afternoon, everyone. I'm Novina from We Collaborate for Nutrition. Thank you, Dr. Sebanti, for the warm welcome note. But before we begin the workshop today, I'd like to share some of our general housekeeping rules to maintain a smooth flow of the meeting. We encourage participation from all the participants throughout the meeting, which has been scheduled for 1.5 hours, which is 1:30 p.m. to 3 p.m. This may be done either by clicking on the icon to raise your hand is at the bottom of your screen, or by sharing your questions, comments, feedback in the chat box, which is on the panel at the bottom of your screen. Through automatic settings, all the co-hosts will be able to view your comments, feedback, and they will be shared during the course of the workshop. We will be taking questions in English and Hindi. As moderators, we have turned off the video settings of the attendees and muted all your mics, so that there is no unwanted interruption in between. Since we are in the interest of time, I request all our facilitators to stick to the time limit given to them as per the agenda. To keep the workshop more engaging and interesting and interactive for all the attendees, we have a quick round of polls to understand your views on some of the key issues. We will be having 5 sessions and a discussion round during the workshop. On providing an opportunity to ask questions, please give a brief introduction and avoid unwanted background noises. The meeting will be recorded for us to collate all the questions and develop a report later. So before we begin, we have now, we'll begin with the agenda. Next session is, I'd like to welcome our guest speaker, Dr. Alok Ranjan, Country Lead for Nutrition, Bill and Melinda Gates Foundation, and Sanjeev Sridharan, Country Lead for Learning and Systems Evaluation, Bill and Melinda Gates Foundation, to set the context for today's meeting. So over to you, Dr. Alok and Sanjeev Sridharan.
Thanks, Novina. Can you hear me?
Yes.
Sanjeev, can you hear me? Can you unmute yourself?
Yes. Can you hear me?
Yes, loud and clear.
Yeah,
Great.
super.
So hi everyone. So Sanjeev and I, we haven't done any kind of a run through of this 10 minutes of how we are going to go about, but we had few thoughts in mind. Let me introduce myself. I'm Dr. Alok Ranjan. I lead the nutrition program for the Gates Foundation in India and South Asia. Sanjeev?
I'm Sanjeev Sridharan. I'm with the Measurement, Learning and Evaluation team at the India Country Office of BMGF. Yeah, over to you, Alok.
So Sanjeev and I, we have been really working together and thinking about the nutrition from the monitoring, learning and evaluation perspective. And I'd really like to thank the organizers for this important session and for especially bringing out so much focus on the quality of nutrition interventions, which is very favorite topic for Sanjeev and me at this point of time. Sanjeev?
Yeah, so Alok, I've been working as an evaluator for a bunch of years, evaluating a whole range of different interventions. I like the focus that Live and Thrive and a range of different partners are bringing on quality. Maybe start by telling us a little bit about C2IQ, and then I have a more general question on quality after that.
Great, thanks. So I would say C2IQ is something that started almost June last year. It was a term coined by our colleague from UNICEF, Aryan, and we all have caught on to it. We all are kind of rallying around that C2IQ as a way where the coverage, continuity, intensity, and the quality of nutrition interventions are very critical. And as focus on the first 1,000 days has become a big priority, more and more partners are now thinking about we cannot really achieve the impact without working on these 4 critical aspects of these interventions to increase the coverage, with the continuity from facility to the household level, from across the life cycle in terms of the continuity from ANC to PNC, and in terms of the maintaining the intensity, not just having it for one point of time, but maintaining that high intensity. And the most interesting aspect, I would say, for me is the quality aspect, which we are going to discuss today.
So, as I've already said, as an evaluator, I very rarely actually find a really serious focus around quality. What's your best pitch for why focusing on quality?
So, thanks, Sanjeev. If you look at the nutrition work at the global level, I won't say you will find any document which doesn't talk about having a good quality of intervention. They always talk about high coverage with quality. But what exactly is this quality? The way our RMNCH plus A colleagues have kind of taken a shot and addressed it in terms of the MNCH program, you see a lot of focus in terms of deep dive and defining what quality is, measuring the quality. I do feel that in the nutrition sector, it is there mentioned in every document which is there. Every talks about quality as a part of increasing coverage and scaling up. But if you ask various colleagues, even on the call right now, what quality means, there would be different perception coming from different folks. And I don't think the way we have had a momentum around the various aspects of nutrition, we have done that for the quality aspect. And if you look at the huge push around nutrition coming from Poshan Abhiyan, if the quality aspect could be addressed a bit more, it would really make a huge impact in terms of what we all end up achieving a few years down the line. So I hope that answers your question. But my question to you, Sanjeev, is what aspects of quality comes to your mind for nutrition from the monitoring, learning, and evaluation perspective?
Thanks. No, I think for me, as I think of any intervention, the first question I ask is what contexts are necessary for this intervention to work? No intervention ever works in a vacuum. By what mechanisms does this intervention bring about a difference? And what are the outcomes associated with it? So this sort of magic mantra of context, mechanism, and outcomes are quite important to me. If I take that lens into thinking about quality, I would be asking questions around what kinds of systems and what kinds of support structures are required to maintain quality. So you may have a set of structural measures along those lines. Second, what kinds of processes do we actually study to actually get at quality? And this whole raises an entire field around process evaluation. That's two. Three is a deep question, actually trying to understand in what sense does quality lead towards better outcomes over time. That's important. In addition to this, there are other issues around, we should think about quality in a more dynamic sense, that we are not, I think far too much of our intervention thinking tends to be quite static. We've got to think about sustainability. In an age of thinking about SDGs, it's important that our interventions have long-term impacts. So from my end, I think I'm just delighted that that this rather important set of dialogues are happening within nutrition. Not only do I think there's going to be far-fetched in nutrition in terms of impacts, it'll serve as a model of the importance of quality in a number of other fields, with a focus on Poshan Abhiyan on quality, and the fact that I think like the meeting today and then the rest of the week really stresses there really is a community gelling together. So I think more power to the organizers for bringing a community together. So let's sort of genuinely build a community focused around making a difference, but bring some clarity around what quality means. Over to you, Alok. Take it away.
Thanks, Sanjeev. Very well put. And I think what better way to understand what aspects of quality has the RMNCH+A community been thinking about, and how the nutrition community can learn from that and build upon that, so that we don't reinvent a lot of the wheels that has been created, which would help this community of participants to come together, then have stalwarts like Dr. Rajesh, Dr. Abhay, and Dr. Rajiv to share those perspectives of how they have been looking at nutrition from different angles, and also looking at it from the data perspective. So I would wish everyone all the best for this dialogue and conversation that we are having today. I do agree that it's like a community coming together. And I hope it's more participatory, and so that it is the start of a journey where we all get to collectively understand what quality means for the nutrition work going ahead, and we all can add and contribute to it in our own sense. And just to end at a note where Sanjeev is joining this from Canada at 4 a.m. in the morning. So we both were apprehensive in terms of the quality of the conversation we would have at 4 in the morning without Sanjeev gulp few cups of coffee. But I think we both have been able to have a good conversation. Sanjeev, any last words?
No, just delighted to be part of the journey. Thank you. That's it.
Thanks. Thanks, everyone. Over to you guys, and really looking forward to this conversation. Had been waiting for this conversation, Sanjeev and I. We have been waiting for it for many months. Over and out.
Thank you, Dr. Alok. Thank you, Sanjeev, for this wonderful talk. So basically, today's workshop on quality nutrition service delivery and the role of data in improving the quality is a pre-conference to the upcoming conference from 15th to 18th of September on Delivering for Nutrition 2020. So it is a pre-conference to D4N workshop, which is coming up starting on tomorrow till about 18th of September 2020. So on that note, I'd like to welcome our next guest speaker, Dr. Rajesh Mehta, Regional Advisor, WHO CRO, New Delhi. Dr. Mehta is a Regional Advisor for the Newborn, Child, Adolescent Health since 2010. He provides technical advice and support to 11 countries in the region. He has coordinated the regional QI model, POC QI in SIER, and beyond. He has published many papers in medical journals, has contributed to chapters in several textbooks, and has prepared several national and international training packages. He's a Salzburg Global Fellow on Early Child Development and a recipient of Fellow of Indian Academy of Pediatrics. So over to you, Dr. Mehta.
Yeah, thank you, Sebanti, and thanks Alok for also pointing out that RMNCH community is a little bit advanced in terms of healthcare quality. So what I will do is spend 10 minutes on actually talking about a very simplified approach, which we have intentionally taken. It's a complex area to work in quality of care. And I saw the struggle when you guys were trying to define quality of care or quality of nutrition services. We have gone through that. And it is by design that we thought we will demystify this for our frontline healthcare teams to take it upon themselves to do some point of care quality improvement work while the system is gathering its act together. So if I rush through some of the concepts, the idea was to tell you what we are up to and how does it apply to any services. And health and nutrition can largely be not separated easily. So as RMNCH community, when we work for better health outcomes, nutrition automatically is part of our health care as well. So it is not a strange thing to observe that when labor room or newborn or midwifery teams are together, immediate attention is on breastfeeding, how to start it early and how to sustain that, and using the human milk or mother milk in NICUs is a common problem area which many of the healthcare teams identify. So therefore, healthcare and nutrition together. So you will find some reflections that how these principles can be. And you are right, this is an area of concern, especially in 2018 when these two publications came. There was a lot of things to understand and consider. The Lancet Global Commission on High Quality Health System clearly demonstrated through analysis of 116 countries that more deaths happen because of poor quality of care and not because of poor access to care. So quality is much better, much bigger contributor to non-utilization of services. And in MDG phase, we all suffered not by design, but largely the emphasis was on coverage. So coverage, and quality was kind of diluted. So now this decade should be considered quality decade because coverage without quality, or as people are saying, the whole field has moved to effective coverage. So coverage without quality is nothing. In fact, you end up wasting resources when you do a lot of coverage without keeping quality in mind. Then you have to retrace your steps and then do it differently. In the process, you end up wasting some lives and wasting some other resources. So the commission, the Lancet Commission did mention that 8 million lives could additionally be saved in LMICs in a year if the systems were delivering high quality care. At the same time, in 2018, we were lucky there was another report by WHO, OECD, and World Bank, where it was mentioned that it is a commonplace to observe that the healthcare is not delivered to quality or does not include all the evidence-based elements in health service. For example, antenatal care, it was observed that across the LMICs countries, only 40-45% times the full antenatal care is provided. Sometimes one component is missing, sometimes another component is missing. So all that goes on. Similarly, for child health, assessments are not up to the date, classification not there, referral not effective. So all those areas are there when non-standardized care is being delivered. So this was one good message from this report. And they said that 10% of patients, even in high income countries, actually suffer some adverse events during treatment. 7 to 10% is the health associated infections. And antimicrobial resistance happens because a lot of non-standardized care, non-rational use of antibiotics, and all that happens. And $42 billion are lost every year just because of medication errors. So the idea was to focus on quality of care, because not just because of survival, but extreme costs which we pay in other terms also. So we thought, then let us pick up a very simple definition of care for ourselves, considering just two main domains. That whatever desired health outcomes we have in mind, this healthcare should actually deliver. So healthcare, normally the outcomes are about decreasing mortality and decreasing morbidity. But we understand from healthcare delivery sector that the costs required to deliver that, the number of days admission is required. So are we using extra resources than required? So all that efficiency and effectiveness comes in, but the health outcomes immediately which catch attention is survival and reduced morbidity. We also believe that the second important component to reduce the non-standardization or improve the efficiency of resources is that only evidence-based care must be delivered. So simply, to mention that there are 6 well-known elements, everyone knows this, but each one of them is important when we are trying to create systems which deliver good quality of care. So simplest definition for a healthcare team in the front would be that how much is the compliance to evidence-based protocols. If we are not able to deliver that, that is the basic, that's a basic failure. A lot has to be put into the system to make it quality efficient or quality sensitive. So this book does mention broad strokes of work which are required. So without legislation and regulation, which the Ministry of Health must take forward, we can't just move, because if there is no standardization starting from there, and therefore standards are important, there has to be a quality of care program with the action plan and all that. So therefore it is important that we should have that in mind, that we use that. So let me then continue to share that what else is required. Okay, sorry, I mishandled the slides. So standards and accreditation is one part of the quality. Then education, training, this is very familiar. We have been doing this, but also again the quality of training is poor. But we are very familiar with this input. Then establishment of performance-based incentive to keep the healthcare force motivated is a clear health system function. And then patients, families, and communities. If we are wanting to deliver people-centered care, this particular part of our work is exceptionally weak. We do not involve people into healthcare or nutrition services. If we did not know the preferences of people, how would we deliver good services? So therefore, that is a missing area. But the book also mentioned there is a micro level action required at the health facility, where clinical practices at the front line must be standardized, and use of continuous quality improvement approaches is essential. So what I'm going to do is, in this presentation, I will just focus on this, the frontline work, assuming that the health system is required and is continuously trying to improve the act, and we will somehow, the top down and the bottoms up approach have to meet somewhere. So let me tell you the base of the pyramid approach going forward. So I believe that health and nutrition workers are the key, because they are the face of the system, and people, the transaction, the business is transacted between patients, the clients, and the service providing team, which is health and nutrition. That interface is very important. So my healthcare workers and nutrition workers, they must adhere to the evidence-based protocols and continuously strive to improve the quality of care. And I strongly believe that our workers, when they leave their homes in the morning and go to their workplace, they have the best interest of the client in mind. But it is unfortunate that good people are working in bad systems. Therefore, the delivery of care is not up to the mark. So all our clinical trainings, we are making it now a point that quality improvement skills are given right at the time when clinical training is being provided. So it will not be a surprise in the future if the facility-based newborn care trainings would already include training on quality improvement, and Lakshya trainings on EMOC, SBA would already in India include quality improvement as integrated part of clinical trainings. So in the region, we kept the partners together to prepare a very simplified tool for healthcare teams in the front line to use for continuous quality improvement. So we called it point of care quality improvement, and it uses a very common sense, very demystified approach, a 4-step process to continuously improve quality. Not a new thing at all, 40 years old concept, but our job was to demystify, simplify it so that it does not look overwhelming to the RMNCH frontline teams who are actually doing work in a very poorly resourced system. So we wanted that people should take charge, and they should use the data and the local leadership and the teamwork to start improving things without asking for new resources. And we found that this 4-step process actually enables that. So when we did that SNCU survey 2 years back, it was found that at least 60% facilities have reasonable resources. So the idea was that the healthcare teams in those settings, are they able to convert those inputs? As Sanjeev was saying, somebody has to convert those structured inputs into processes and then to outcomes. Are we able to help the healthcare teams to convert those inputs into good outcomes? So therefore, this is for identifying the problem. The team has to come together, use the local data, and identify what quality gap they want to address. Then they must do analysis of the root cause and then try to evolve solutions and simple PDSA cycle to improve, and then decide whether the solution has actually succeeded or not. If not, then you evolve another solution, another PDSA, and then if it works, then you sustain it. So it's largely about data. So data is used in this process at the time of diagnosis of the quality problem, at the time of assessing the effect of the change which we brought, and then whether we are monitoring the sustenance through data or not. So data, good quality data, is important and is embedded right from the beginning. So our request to our healthcare teams is that acknowledging that there is a problem is the first step for problem solutions. If you don't acknowledge there is a problem, then you can't evolve improvement. So therefore, use your data, and to define the problem, use your actual data. Don't fake it. Be honest. And we constantly believe that we must banish blame culture from the system, and we should never use data for blaming, shaming, or punishing. Data is only used for improvement. Therefore, it is important that right from beginning, we encourage our healthcare teams that please assess yourself, be honest to yourself, and be honest to the system. So our healthcare programs, all of them have this particular element, which is you have to agree upon a data set, an indicator set, and then do monitoring routinely. So measurement in health system is important so much as in nutrition. So therefore, what to measure and where to put your money on measurement is important. And as somebody said you cannot fatten a pig just by measuring. You have to do actions as well. So therefore, each data point has to be associated with an action. Continuously measurement will not help. So therefore, this was the observation from the high quality health system, the Lancet Commission. And we are trying to absorb much of these principles, that there should not be any fragmentation. Mostly outcome data should be useful rather than too much of input data. And we should now, effective coverage should be measured. So that is quality corrected matrix is important. So we understand this paradigm that much of data is required at the front end. All this data which is used here does not need to travel to the national level. So much of data about process of care, about the outputs of care right there, is constantly emerging and being used by POCI, point of care quality improvement. Each quality improvement project around improving breastfeeding will have a lot of data use, process and outcome data, which continuously changes and being monitored. So then they move on to another QI project, to another. So a lot of data would be there, which will be useful for improving, but does not necessarily have to travel upward. Similarly, there would be some data required for monitoring all this quality improvement work on health and nutrition in all the health facilities, in community, in outdoor settings, in referral level settings. So the quality of care is important everywhere. So data emerging all of there in a district, there would be some data around program management also, which will be required. So a few critical data, for example, how many babies initiated within 1 hour within the labor rooms, that would be a good process of care data, which may be useful. But I must warn ourselves that in third month of monitoring, this will become 100%. If you are asking every time how many babies initiated, very soon the social behavior of data travel is, data use is, that very soon you will have 100% achieved. Then nothing to discriminate subsequently. So that blame culture, that honesty, that must become the part of work culture. So therefore, POCI approach is important. And then the sum of data will travel to district, and then there would be some national level monitoring happening at. So all nutrition, healthcare program, education programs need this approach, and health and nutrition can actually be done together.
Dr. Mehta, sorry to interrupt. We are.
So my last message is that we must convert data into wisdom, and there is a hierarchy, well-known hierarchy. We must convert data into information. As I said, in POCI, we do root cause analysis, and we convert that into some actionable data, and that gives us knowledge to change. And then we decide the change, and with a lot of wisdom, with experience, we come down to that each baby and the mother have to be together to improve skin-to-skin care and breastfeeding. Therefore, the data must be converted into wisdom. POCI is just a tool. So let us join hands and let's use data for improvement. It's a long journey, but we thought we must start at a very simplified micro level in the facilities where a point of care is important, while the system is coming together with all the support which these healthcare teams need. Thank you.
Thank you, Dr. Mehta, for the wonderful presentation on the quality. Dr. Mehta, can you hear us?
Yes, please.
Yes. Thank you, Dr. Mehta, for the wonderful presentation on the quality improvement in the health and nutrition service delivery and sharing the best practices, through the use of data. So for our next session, I'd like to welcome Dr. Aba Mehndiratta, Country Director for India Institute for Healthcare Improvement. She's going to be presenting on how quality of nutrition services can be improved by the use of data. Dr. Mehndiratta is heading the Institute for Healthcare Improvement. She is a pediatrician by training, quality improvement expert by profession. Over to you, Dr. Mehndiratta.
Thank you so much. Are you able to hear me?
Yes, but you can be slightly louder if you could. I don't know, your voice is a little low right now.
Good afternoon, everyone. A pleasure to be here with all of you.
Yes, you're audible, Dr. Aba.
Yeah, thank you. I'll start now. Thank you.
Sure.
Well, so we're talking about quality, and every system is perfectly designed to give us exactly what we're getting today. This picture is from an Anganwadi in northern India, which I visited last year. And I think it speaks for itself.
Dr. Aba,
it's very hard to imagine. Am I more audible now?
Now you are audible. You were breaking in between. Okay, carry on.
Okay, yeah, thank you. Well, this picture is from an Anganwadi center in one of the North Indian states. And when I visited it, it was filled with lovely children smiling and laughing. But it was very quickly apparent that there wasn't a weighing scale to weigh them. There wasn't a height chart to measure them. And the system was designed that it was really not possible to pick up any child who might possibly be underweight or be stunted. So if we want the system to move differently, it is really important for us to make changes. And is there a systematic approach? Is there a science for improvement that we can apply? And how data figures in that is what I'm going to be briefly speaking about today. We are very familiar with subject matter knowledge, and it's very important. In nutrition, we have modules for clinical modules on what is the right kind of food to be given to the pregnant women, when to start complementary feeds, how to prevent and treat anemia, and that is really, really important. But I think the collective experience on the call today, I assume, because I can't hear from you, you would agree that when we take this evidence-based clinical knowledge into the real world, it becomes very difficult and different to apply. India is not one country, and even within one state, one district is very different from the other. And there are a lot of contextual reasons and barriers on why it's difficult to have knowledge that we know is important and needs to be given to every child and every mother. It becomes difficult to translate it. And that's where the science of improvement can be very useful. And it's the place where the two interface, the clinical knowledge and the science of improvement, is where we see that quality of care actually changes and improves for the better. I will very briefly speak about the science of improvement. I have only 10 minutes. I think I can speak a day if I go in detail. But there are four main lenses for the science of improvement as articulated by Dr. Edward Demings, who is said to be one of the founders of quality improvement. The first one, he said it's very important to appreciate the system in which we are working and trying to bring the change. As you're very well aware, Kerala is very different from Bihar, and then within Bihar, certain districts are very different amongst each other. And it's important to understand what are the contextual reasons, what are the processes within the system that we are working towards improving. Equally important, the second lens, as he mentioned, is the human side of change. The interplay of the different people who make up the system within a team, within different levels of the system, within the facility team, but then amongst their supervisors and senior management structure, and how to build the intrinsic motivation to try out new changes to improve outcomes that matter to us, to improve care that's provided to children and women. The third very important element, which I'll be speaking more in detail, is about understanding variation. Dr. Mehta has very nicely actually captured a lot of the important points that I wanted to make. So I'll be just reiterating what he said in the earlier presentation on why is it important to be very careful when we are measuring data, how we are using data, and are we using data for improvement, or is it by mistake being used to judge people? And I'll be elaborating more in the subsequent slides. And the fourth one is around theory of knowledge. And theory of knowledge is building knowledge that in the context that we are trying to make improvement, what changes have worked and why they have worked. So that over a period of time, we know that if we had to take this knowledge to another place, a lot of these changes may work. But of course, when we take it to a different context, we again need to test and learn. So it's a cycle of iterative learning. You might be very familiar with the dashboard. I've taken this out from the Niti Aayog dashboard for comparison of states and comparisons of districts. And just as an example, this is taking the indicator of children under 6 months who are exclusively breastfed. And the point I'm trying to make from this slide is that the variation is apparent. You can see that certain states are doing better than others. And as Dr. Deming said, for quality improvement, if I had to reduce my message for management to just a few words, I would say it all had to do with reducing variation. And I think that's why we are having this webinar today, to understand what we can do to identify why certain states are doing better than others, and what practice can be taken to another place. And then even within a state, as I mentioned earlier, there's going to be a lot of variation. And if we are able to decrease this variation to the minimum, I think our job will be done, and we really would not need to worry so much about quality. So what to measure? There is so much of measurement that is happening. These are just some guiding principles for us to keep in mind when we are thinking of indicators and measures. Are we measuring what really matters to people? And some of the key examples I've taken from the 6 dimensions of quality recommended by the Institute of Medicine. For example, is the care effective? We were earlier seeing an example of exclusive breastfeeding being given, and we saw that the rate was quite low and with a large amount of variation among states. But we know this is an evidence-based practice. So are we giving evidence-based practices? Is our care effective? What are the exclusive breastfeeding rates? What is the prevalence of good nutrition within the community that we are serving? Is our care patient-centered? What is the experience of the mother who comes to the village health and sanitation nutrition meetings? What is the experience of the mother who comes to the monthly PMSMA meetings? Is the care timely? Were we able to identify the child who was becoming underweight well in time before he moved into severe malnutrition? Is our care efficient? What are the delays we are looking at when we are having mothers coming to seek care at the ANC clinic? Is it equitable? Is it able to provide equally for different populations within the system that we are taking care of? So these are some broad principles when we are making measures which can help us reflect, are we measuring things that people value? This point I would probably elaborate, spend a little more time with a number of slides, is the question, why are we measuring? And often we find that the reasons for measurement, the lines get blurred. Are we measuring for research to produce new knowledge? Are we measuring to judge and to tell who is better than the other? Or are we measuring for improvement, as what Dr. Mehta was saying in his earlier presentation, to understand where we are, and then with that acknowledgement, with that transparency, try and find out what are the reasons, what are the problems, and why we're not doing well, and find ways and changes to improve. And often while we collect a lot of data, as I said earlier, the lines get blurred. So when we have research, we require a huge amount of data, as much data as possible to be collected. In the real world, we do not have that luxury. We do not have the resources. So in improvement, you will be collecting just enough data for me to understand what is the problem and to know the change that I did it lead to any improvement? In research, we try to eliminate all kinds of bias. In improvement, bias is part of the process, because we are using the data on a continual basis to learn what are the problems and then to find solutions. But the biggest problem happens when data for improvement by mistake gets used as data for judgment. And we are increasingly realizing not only how critical measurement is to quality improvement, but also how often it can be counterproductive if we mix the measurement of accountability or research with the measurement for improvement. And I'll show it in an example in the next slide. If anybody wants to know a little more about the 3 phases of measurement, this is a paper by Solberg, Mossad, and McDonald, which you can refer and read in more detail. Well, this is a health and nutrition dashboard. I've taken as an example one from Maharashtra, where you can see the various districts of Maharashtra are quite brightly colored in green. And across many different indicators, these colors are changing. I do not know how the government over there utilizes this data, and I'm not judging or making assumptions. But what I've seen in my own practice for other indicators where similar kind of color coding is used, that while we think that we are doing this color coding to identify facilities or districts or teams which are performing well, if there is a yellow, we will be cautious, and then we'll be prepared to do something to make improvement. And if there is a red, it's like a warning and it's alerting us on when to act. However, often it's used in a very different manner. When it becomes green, we are at risk of becoming complacent, that we are doing well, we don't need to do anything further to become better. There is also the risk of wanting to be always in the green, because we don't want to have any punitive action to be taken if we are in the yellow and red. Somebody is judging our performance based on that. So do I have the right incentives to be really honest and to report my data correctly? And with red, often it is, and I've seen that at different levels of the health system, let's find the person who is to blame. Let's act on something. We are on red. Rather than looking into the system and what are the problems of the system and how it needs to be changed for improvement to happen, it often becomes on finding the person who's to blame. So just reflecting on some of the key principles of measurement when it's used for improvement and not for accountability and research. The purpose of quality improvement is learning. It's not judgment. We are aware that no measure is perfect. All measures have limitations, but the limitations do not negate their value. There is always some learning associated if we are wise enough to identify reasonably good measures. We need a balanced set of measures. We need measures, definitely those which can measure outcomes which are important to us, outcomes which directly measure the clinical quality as well as the experience of the patients who are receiving the care that we are providing. But we also need to be able to measure processes which will help improve these outcomes. And also balancing measures. These are measures which are trying to keep a watch out for any untoward effect that may happen in the system because of changes made in one part of the system, which have a negative effect on the other part. And it depends on how frequently we're using the data. If it's a frontline team which is making changes on a daily basis, the more frequent data they have, the better, at least daily or weekly data. But if the team has a stable process, it's not actively making any changes in that process, then monthly data should be fine. It's important that the measures are linked to what the team has identified as an aim for improvement, so that it is utilizing it to see how it is progressing over time. Measures you should be used to guide improvement and test changes. Dr. Mehta very rightly said, we cannot fatten a pig by just measuring it. It has to be associated with changes and action, and data guides us through that. And we should make the data collection and the data analysis as simple as possible. As much as possible, use data that already the system is generating and try to integrate it into the team's daily routine.
Dr.
Very important.
We are running a little short of time. So yeah, I request you to,
I will conclude in the next few minutes. Yeah. And for the data to be plotted over time, preferably with annotations for us to know what changes were done when we look back on why certain improvements happened or did not happen. And very important to focus on the vital few. Very briefly, and again, reflecting on what Dr. Mehta was saying, it's incredibly important that we build capability of the front line to be able to reliably record and report the data, as well as collect and analyze the data. The closer the data is analyzed at the point where it's generated, the less we are looking through the rear view, trying to retrospectively fix the system. Because the people closer to the system know their problems best. And if they know how they're performing, and if they are given autonomy and supported to do improvement, that's where the greatest amount of change is going to happen. So for leaders, the earlier slides are important. You need to support your teams if you see the numbers are not looking good. And it's incredibly important for leaders to build capacity of the frontline teams to not only record and collect and report, but most importantly, analyze the data during their quality improvement meetings and see whether it's leading to improvement or not. I'll just conclude with last 2 or 3 points. Transparency. And transparency doesn't come on its own. It's a reflection of the culture in which the health system is performing. And leaders and managers have a critical role to play. If we are able to build confidence within the teams that this data is going to be used for improvement and not against them, teams will be encouraged to be honest about the results and progress that is happening, of things that are working well and even the defects that are there in the system. And lastly, whenever possible, put a face to the data. This is a story from a lady who came in Gopalganj, was identified with severe anemia, was provided injection iron sucrose in the antenatal period, and went on to deliver within the facility. And you can see a smiling baby in that slide, because behind every number is a person. So thank you very much.
Thank you, Dr. Abha. Thank you very much. Our next session is on why improving data quality is important to improve these services. For that, I'd like to welcome our guest speaker, Dr. Rajiv Acharya, Associate with Population Council. Dr. Rajiv Acharya is a statistician, demographer, and a public health specialist with more than 2 decades of experience. He works on sexual and reproductive health issues of women and men with special focus on family planning and abortion, nutrition of children and adolescents, adolescent health, and improving data ecosystems with a focus on data quality. Over to you, Dr. Rajiv. Dr. Rajiv, are you able to hear us? Can we unmute Dr. Rajiv? Dr. Rajiv, we are not able to hear you.
Is that okay now?
Yes, sir. You're audible.
Okay, thank you. So sorry. Thank you for asking me to present this on this topic, why improving of data quality is important for nutrition services. And this is, of course, a part of the main conference, which is Delivering for Nutrition 2020 conference. I'm sure a lot of you will be, attending that. So I don't know. Okay. So I'm presenting it on behalf of National Data Quality Forum, which some of you must be knowing is a forum where our goal is to galvanize action among producers of different kinds of data, demographic data, health data, nutrition data, towards improving its quality. The three major thrust areas of this initiative. One is deepening the interest on the importance of good quality data among both who produces the data and who consume the data, and then developing and testing the effectiveness of pilot technological and behavioral change solutions to improve the data quality, and finally supporting institutions in institutionalization of data quality assurance mechanism within their own institution. So our NDQF is envisioned to work with institutions to conduct who are conducting managing the routine health information systems. As a result, it's a partnership model. We all come together to do it jointly. And you can see some of the potential partners who are already working with us. Some are going to be working with us very soon. And important people like NSO, National Statistics Office in MOSPI, or IIPS or HMIS division of MOHFW are important partners in this endeavor. Let me come to the topic. So I start by saying data quality is important for nutrition services, and how. There are different kinds of data on nutrition that we get to collect or talk about. One is survey data. The previous presenters showed some of the NFHS data, survey data that provides macro level view of the progress made over the time. As she was saying, showing NFHS 3 versus NFHS 4. Quality is paramount for this survey data for appropriate policy response to the progress made or not made. So if the indicators go haywire, it is very difficult for policy to respond appropriately. But fortunately, it is very much possible to collect good quality anthropometry data. There are other data, the breastfeeding data, there are biological data that is collected. But I'm only talking about anthropometry data for now. And it is possible, for example, to collect good anthropometry data in surveys through extensive training by experts, proper standardization of measurers and assistants, and then testing them and standardizing them, and then finally closely monitoring of data collection. Very good quality anthropometry data are collected in CNNS, as you know this survey very well by now. There are other kinds of data also collected in CNNS, for example, bio, where excellent quality control mechanism was in place. And similarly for the survey, the monitoring was one of the biggest contributor to the good quality of data. But today I'm not going to talk about survey data. I'm going to talk about the program data. That is another kind of data on nutrition that is important, that provides micro level data for managing malnutrition at the community level. Okay, and it has immediate relevance to the nutrition services. This is a very common known malnutrition management cycle where workers, the community care centers like Anganwadi centers, their children come and stay together. Data are collected there by the Anganwadi workers on different things, for example, age, sex, their height and weight, etc. Data are interpreted by them, and then their referral happen from them. So they refer the growth chart available to them, look at the stunting, wasting or underweight measures, and then refer them to the facility-based care if they're severely malnourished or something like that. And this process goes on, this process goes on. There are two places where there could be problems here. It's a very nice system. The one is the data collection. You have problems with, you can have problem with age data, which is now minimized. Probably everybody has their own, birth certificate and those probably nowadays. Then we have problem with height data and weight data. Either measurements are not taken regularly, or even if they are taken, they are not taken accurately. This is a problem. Second, the data interpretation level. Because of the training issue, there could be inaccurate or wrong interpretation of the data that they are collecting. So there are kind of issues here that affects the quality. One of these, among all these different measurements, one that is height is one of the very most difficult one to measure by the people who are not trained well, not standardized, not really retrained once and again, is the height. For weight, you have now digital scales. If there are digital scales available, it's not that difficult to get weight recorded. Sex and age are not that difficult. Is a height, for example, is one of the most difficult indicator to measure. So what we did, we just tried to see one of the very stunting, how sensitive stunting is to the error in height measurement, for example. We took CNNS data from Andhra Pradesh, where stunting prevalence for children 0 to 4 is 31.5. What we did, we split this file into two parts, one with 20% of the random sample, and then another is 40% of the random sample, of not measurers. That is one wrong typo actually. So it's 20% of the sample, where and then we added 1 centimeter to them, or we taken away 1 centimeter to them. If we add 1 centimeter for the 20%, in the 20% sample where the error is induced, the stunting decreases by 0.9%. However, if you under measure by 1 centimeter, it increases by 4.1%. You can see how stunting is so sensitive to height measurement. If suppose 40% of the sample has been induced with some error by over measuring it by 1 centimeter or under measuring it by 1 centimeter, you can see the stunting decreases by 1.7% in the first case, and increases by 5.3% in the other case. So growth monitoring is difficult in absence of good quality anthropometric data, because the indicators that we use generally, for example, stunting, is very sensitive to the measurement errors. What are the solutions? We talk about quickly two types of solution. One, whether we can avoid things that are very difficult to measure in the field level by the Anganwadi worker, for example, height. So can we replace height by something that can give us sufficiently good control or monitoring tool to monitor our progress? Prior research has indicated that the two indicators, height and weight, may be biologically related, and increase in weight may be associated with increase in length or height. So why not use weight? Weight measurement is simpler, does not need much training or standardization. Very accurate digital weight weighing scales are available, not extremely expensive, that can be afforded at the community level.
Dr. Rajeev,
yeah,
in the interest of time, yeah, sure.
So we examined CNNS and NFHS4 data to understand the relationship between height and weight in this Indian population. We see that nearly 2/3 of those who were stunted were also underweight. Similarly, about 3/4 of those who were wasted were also underweight. So these findings indicate that in those places, those communities where the data quality of height measurement is questionable. Underweight should be able to track the growth data, growth status of the children to a large extent. And then finally, we look at the technology to take over from the human error that we make. So image-based anthropometry is one of the options. Height measurements to photos, accurate considers environmental challenges like where these children are located. Cheap, even a mobile can be used for that. The only so far challenge is the length of a baby, which could not be very accurately measured with image-based anthropometry. Weight measurements to photos is a work in progress, and accuracy is still an issue. This is already being used in India in the SNEHA project in Karnataka. Well, technology can take over. We must remember the privacy is a concern when you use technology too much. Thank you.
Thank you, Rajiv. Thank you, Dr. Rajiv, for sticking to time, but we are still running a little short of time. So we go to our next session, but before that, we will do a quick poll. I would request Praveen or Vishal to set up the poll, where we would like to know what our participants are thinking about a particular issue. So Praveen, can you set it up on the screen?
Naveen, it's already on.
Okay, it's already on. Great. So we go on to the menti.com, www.menti.com, and we use the code 2312904. And we would like to know what word or a phrase which comes to your mind when you hear about the quality in nutrition service delivery.
And I have also shared a link in the chat box, so people can use that link also too.
Yes, you can click on the link and respond to this. And we already see a beautiful word cloud on the screen. While we do this, maybe I'd like to introduce Thomas for our next session, which is basically a discussion round on identifying the priority themes for defining the quality in nutrition services and role of data to improve the quality. So over to you, Thomas.
Thank you very much, Navina. Can you hear me?
Yes, you're audible and you're visible too.
Perfect. So thank you so much for all of those inputs on this poll. I mean, it seems that practice, knowledge, and data are really the three things that keep popping up as the three big topics that people have in mind when thinking about quality. So what we would like to do now that we've heard a lot about some of the experts in quality, what we would like to do is bring some of the experts in nutrition in and have a couple of questions for you. And the first question that I would like to ask the different participants as we can see the poll data quickly evolving is, what are the components of quality we should address to improve the quality of nutrition service delivery? So let me ask people by name, because we have little time. So I would love to make sure that we have the ability to get the views of some of the participants. So Devaji from CARE, we would love to have some of your views. Please keep it super short on what are the components of quality we should address to improve the quality of nutrition service delivery. Devaji, please.
Yeah. Hi, Thomas. As you see in the, am I audible, Thomas?
Yes.
Yes, you are.
As you see in the word cloud, targeted practice, knowledge, and data, and knowledge has been continuously in the center. If the whole aspect of data quality to me means practice much more than knowledge. And essentially it means that local data that is available collected by the frontline functionaries should be available for them to use that data. And this will be my initial remarks. And I feel that supervision and the role of supervisory cadre in ensuring quality of nutrition service delivery is crucial, and they become the critical point, the critical link between quality of nutrition services and quality of the data what is being generated currently by applications like common application software. Thanks, Thomas.
Thank you very much, Devaji. Could I ask Mini Varghese from Nutrition International to come in next? On the same question, what are the components of quality we should address as we think about improving the quality of nutrition service delivery?
Thank you, Thomas, for the question. For me personally, I would say that, all inputs which we will be putting it for the nutrition intervention, that has to be quality. So that means the practices that we do it at the periphery has to be quality input. If until unless we have a quality input, we will not have a desired outcomes which we can have to measure it. So before we start looking at the data, we need to set in place capacities, systems and structures that which we have already, some of our speakers has talked about it. These are critical foundational work that we need to focus on it. I would stop here for others to respond. Thank you.
Thank you so much, Mini. Could I ask Dr. Sunjit Ranjan from CFNS to come in next?
Thank you very much, Thomas. And I was going through this, and lots of important things are there. But from my point of view, I think the most important is what I feel is the capacity of our functionaries, the public health nutrition functionaries. And when I'm saying capacities, there's a kind of conviction. Yes, this will work. This will deliver the good result. And that is the most important thing. Apart from that, I would like to say the supply chain management. That's the very important component, and under the procurement, the distribution of the essential supplies, that plays a very important role in the quality program. And I personally feel like the data culture, already we have talked a lot about that, but the data visualization, data interpretation, and the data sharing, the right kind of data reaching to the your service providers as well as the key program participants. That's the key important things from my point of view at this juncture.
Thank you so much, Dr. Sujit. May I ask Dr. Amir Khan from the Indian Association of Preventive and Social Medicine to come next?
Hello, Thomas.
Hello.
Yes. Okay. So this we have been working with the Alive and Thrive, IAPSM, Alive and Thrive, and the local medical colleges in Bihar and Uttar Pradesh in the last more than 1 year. Due to COVID, there is we have paused. So what we learned from all these experiences is that the inbuilt supportive supervision system that is there already in the program needs to be strengthened. That is number one. Secondly, as has been told about data, data should be open for research also by the medical colleges. There is a lot of bureaucratic hurdles to access the data because many postgraduates in community medicine and even medical undergraduates and social science students, they want to do research. They want to bring out that information and highlight it. But that is another thing that I think open data. And third, I think is that medical colleges, if they can be involved, because what we are doing, we are seeing how medical colleges, community medicine departments are involved in this quality monitoring, and it helps. So that would, I think, may further enrich the things, supportive supervision thing much more. So I think that is inbuilt supportive supervision, I think, is one of the very important things. that we need to take care of.
Thank you so much for your very valuable input. Could I ask Divya Nair, Dr. Divya Nair from ID Insight to come next?
Hi, everybody. Yes. So in terms of quality in nutrition service delivery, I think, some of the points that were made earlier are really valuable. And one point that I think really stood out to me is the reduction in variation in service delivery, basically raising the bar across, various geographies. So to do that, I think you need a lot of contextualized information that's local, that's consistently defined across, various geographies. And once you have that, then the two areas in terms of at least the data piece is the production and the consumption of data. So once the production of data is more standardized and there's a sense of understanding what everybody's collecting, then in terms of the consumption of data, all these conversations around data culture, data use become really important, ensuring that there's a feedback mechanism where data is used at various levels and different pieces of data are collected at various levels, so that quality is like a uniformly understood concept and the person who's collecting the data is not punished for reporting bad news, but is actually supported for providing feedback on how things are working. So I think, converting knowledge to practice and practice to knowledge, as is the central part of this word cloud, I think is the core, and data helps to kind of bridge both of those. Thank you.
Thank you so much, Divya. Can Dr. Vikra Datta from NQDCN come next, please?
Yeah, Thomas, good afternoon. So what I would just like to mention here, I've been listening very intently to all the esteemed panelists. I have been having some chance to be associated with the Indian Academy of Pediatrics IYCF chapter as we worked in Rajasthan and also dealt with the micronutrient initiative with Government of India right through the length and breadth of this country, preparing a policy document and trainings for that. I believe it is time to move from data to action. That is the first most important thing. We've had a lot of data. We've had NFSS 3, we've had 4, now we have CNNS. We all know things are bad. And if you compare 3 and 4 data, your early initiation of breastfeeding still 40%, complementary breastfeeding rates are falling, your bottle feeding rates are going up. So basically data is telling us that things are going wrong. When we get honest data, it tells us things are going from bad to worse. Now the time to move to action. Now what should you do? Well, I being the president of one of the organizations which is leading a network of quality in India, I believe we need a very strong quality improvement program which is designed with active community participation, because we are all experts here. We are debating on an issue which is directly of concern to the community without having an active participation from the community, or what does the community feel how the quality needs to be improved. I think that is something which is very important, and this can be done by bridging the no-do gap, as the previous speaker just spoke, and this can be done by another innovative approaches, 2 of them. And one is the translating research into the practice framework, which we have tried and tested all across country, and a modified hub and spoke model. So these are the 2 methods with which implementable quality improvement program with strong community partnership involving the frontline health workers into the peripheries of the country to change community behavior and make the program reach them. So that's all what I have to say.
Thank you so much. Very useful. Can I call Indrajit Chowdhury from PSI next?
Hi, Thomas. Am I audible?
You are.
Yes. So 2-3 things I'd like to speak. All other guests and speakers have talked about most of the things anyway. I think in nutrition we have always faced that there is a huge problem, or probably we are not measuring the quality as much as we are doing in other MNC services. And specifically, when we talk about it, we should look into, there are 2 kinds of measurement. One is a measurement in the facilities, which are happening pretty well. But measurement for the outreach related services are, there had always been a lack of that. And when you measure that, we need to understand what data to collect, which is actionable. Everything is not actionable. Like probably getting a data at a very, very high level, outcome level, can probably take a lot of strategic decision on that. But for the quality of intervention or improving quality of intervention or improving the program, you can't take an action. So what data to collect which is actionable? And the last thing probably I'd like to talk, and which is a dilemma against, is a standardization versus contextualization. Whereas measurement always demands a more standardization of the process, which makes it easier for measurement, but context, the quality is and needs to be looked into as for the context, as Sanjeev started with context, mechanism, outcome framework. So we need to look into that framework. So how to do that measurement, and that requires a more discussion and probably more specialist discussion with more specialists on that. So that's all.
Thank you so much. May I call Dr. Rajesh Khanna from SAVE next?
Yeah, hi, good afternoon, Thomas. Yeah, very interesting discussion going on, and probably I'll just carry from where Dr. Vikram Datta just said, because we have been focusing too much on nutrition service delivery from the supply side. But when you look from the community perspective, what are we seeing them first of all? You know, what are their expectations of a quality? And do we see them as a beneficiary? In that way, we are already making a big error in thinking about the quality. Or are we seeing them as equal participants in the delivery of care? So my thought would be, you know, when you think of a data, and this is a problem that we are seeing even from MNCH services where certain efforts have been made. And if I remember correctly, Dr. Mehta just said that people-centered care is one of the weakest links. And I think if we're talking of nutritional services, that indicator and this issue needs to be prioritized at the highest level.
Thank you so much, super useful. Can I ask Robert Rodson from UNICEF to come next?
Yes, Thomas, thank you. This is a really important topic that is very close to my heart, and I really appreciate all the inputs, especially Dr. Acharya showing how the changes in height can have an impact on stunting, and Dr. Mehta showing that each data that we collect has to be tied to an action, and then Dr. Mehirata, as Divya said, the focus on reduction of variation is the easiest way to translate the goal that we want to achieve with achieving data quality. So I'm thinking in the terms of of looking at infant and young child feeding, and you can see a seasonality in wasting, in low birth weight, and in exclusive breastfeeding and complementary feeding, and why children in this day and age should be exposed to any sort of negative, dangerous effects from seasonality is not acceptable. So we have to define what are the quality aspects that are changing during these seasonal variations, these seasonal trends, to be able to reduce them. And I think that it's not rocket science. We're able to define what the problems are. We need to come with the proper data collection tools that allow us to be able to collect information on it and to be able to respond to that information. So we know that wasting will go up in the summer and into the rainy season. So how do we define what inputs we need to intervene upon to prevent children from being wasted, to prevent exclusive breastfeeding from being affected, to prevent children from being born low birth weight? We just have to define what those aspects are, and we just have to go back to our training materials and pull out the relevant pieces and start to measure this. So it's not rocket science. I'm looking forward to seeing the way that these can be built into protocols and implemented. Over.
Thank you so much, Robert. Can I ask Dr. Sharika Yunus to come next?
Thanks a lot, Thomas, and good afternoon to everyone. I would say that I agree with all the previous speakers, but if I were to look at which area is quality perhaps brought into from my perspective and from my organizational perspective, and it's also good to see that some of it that did come into the word cloud, is the quality of the supplementary nutrition or the foods which are provided through the Integrated Child Development Services Scheme. Within the supplementary nutrition, I'd focus largely on the take-home rations, which are given to children between 6 to 36 months of age and to pregnant lactating women. We do have evidence from the National Family Health Surveys, etc., which do say that the take-home rations or the supplementary nutrition is the pull for services in the ICDS. And it also then perhaps could be used or leveraged to improve things like infant and young child feeding and preventing malnutrition ultimately. However, those connections have not been able to happen or be operationalized in the field, largely because the quality of the products that are often distributed to pregnant lactating women and to young children are suboptimal. If the quality of these products could be improved, then perhaps we could have a natural link to improving complementary feeding practices and then on preventing malnutrition. And by quality, I just don't mean the product per se, but quality in terms of packaging, so that the community is assured it's a good product which is being given to them. Quality in terms of linking it with social behavior change communication, quality in terms of production processes, quality in terms of the testing, etc., that they're able to go through before they're qualified as a good product fit for human consumption. So I'll leave it here, and perhaps if there is any further question, then try and talk about it in a bit more detail. Thank you.
Sure, thank you so much, Sharika. So, I mean, I think this is actually fantastic, because I think all of the discussant and the speakers before them for all of the inputs, and I find this is really interesting, because we're looking at this word cloud that is in front of us, and there's three big buckets that are emerging: data, knowledge, and practice. And when I was listening to the conversation, really the one that popped up and that was not as clearly outlined by our various participants in their triptych of data, knowledge, and practice is the customer or the community, starting with the customer and the communities and moving to data, moving to knowledge, and moving to practice. And that's really what we want to do, working with you in the coming months and years, is really drive this agenda for quality and try to actually make it part of how the system functions. And one of the things that we've been thinking about for a few months is how we could actually initiate a joint effort to drive this agenda for quality for nutrition. So we're already over time, so I'm just going to ask for one or two volunteers to give us some advice in terms of how we should go about initiating this joint effort. And then because of our time constraints, we'll follow up offline with some of the participants to just make sure that we can bridge from this very informative discussion to action. So I'm just going to take volunteers, because I really can't go through a broad review as we're really already running over time. Any inputs or any last word and recommendation in terms of how to move forward from some of the discussants or speakers?
Thomas, this is Sujit from CFNS. And I think you have raised a very important point, and just two suggestions from my end. Like based on my learning, it's important to understand some of the linkages like the linkages between family planning and nutrition, or the linkages, girls' education and nutrition. It's important to understand that so that we can incorporate in a more effective and meaningful manner. The second thing which I would like to say, like this is the time it's important to engage the community in a very effective manner. When I'm saying engage, like the community-based institutions, how the community-based institution can play an active role in supporting solution at local level, such as generating the self-reliant populations, work in support, government's initiative also facilitate ground activities, even the data collection and the monitoring of the mechanism. So these are the very important things which can bring very good result in a very short span of time. And at the same time, I would also like to add just last point, like the integration of the a couple of platforms. So it's the mapping exercise is very important. Who is doing what kind of interventions, how that is adding value to nutrition. I think at every level, if that kind of information is there, it's very easy to integrate, very easy to collaborate. Thank you very much.
Thank you very much, Dr. Sujit. So I see we're at time. So for the different participants who are registered into other pre-conference workshops, I think there's one that is just starting now. So I don't want to retain you. For those of you who want to stay behind for a little bit, then we can just conclude the conversation with a couple of additional words of wisdom from our discussants, and then I'll let Praveen talk a little bit. But I think most of the people will want to move to the next set of activities. So I'm just gonna thank you very much for your contribution. And I want also to, and thank you, Vishal, for doing this, to point to your attention that we have a plenary on the 15th of September tomorrow at 5:30, where Margaret Crook from Harvard will talk about quality further. And she's a very well-known professional in quality, so you'll have the ability to build on some of the discussion that we've had with additional input from the ministry as well. So thank you so much for everybody, and I'm gonna let people go. But just if some of the discussions elect to stay behind, I can take a few other recommendations in terms of how we should move forward. Any further input, or should I make Dr. Sujit have the last word?
Maybe we can go to Dr. Sujit now.
Yeah.
Sorry, I think I was meaning that he just spoke.
So Thomas, I think I could very quickly add a few points if you allow me.
Please.
Yeah. So basically, Thomas, I have been working on the micronutrient part and also the human milk banking systems in state of Rajasthan, and trying to improve the nutrition and also quality improvements across care around the birth practices, early initiation of breastfeeding, and exclusive breastfeeding, etc. And being a neonatologist per se and technical lead for Lakshya, these are my areas. So basically, we should try and divide our implementation plan into two parts. One is the short, that is the first 6 months, and then the long term, maybe 6 to 18 months. And at the first part, the most important, and we've been advocating Government of India. Well, I'm a part of Government of India, I work for the Ministry of Health. So we've been advocating it to the Commissioner for quite some time now, and we've given a report to him also. It's about notification of a TRG first. So the first step is notification of a TRG, and then setting up a process for mapping and a RCA exercise, that is a root cause analysis exercise, and that too not for the whole country, but in a high-risk population settings across India. You know, so you pick up subsets across the various areas of the country, And depending on the conditions, you prioritize the conditions according to the prevalence, the cost of management, ease of identification. So you could pick up your own, yardsticks to prioritize which are the conditions, because, nutritional problems are multiple. So you could you could have micronutrient, you could have iron deficiency, you could have protein malnutrition, you could have a combined type of malnutrition. There's so many things. Community participation, I've told you earlier when I was earlier addressing it. Then conduction of capacity building. When we all know that the capacity building sessions are only 10% effect size, less than 10%, and changing the health worker perception according to a recent Lancet systematic review. So we have to build up the capacity, but let's not be totally focused on building capacity and monitoring. That is what traditionally India has been doing for quite some time now, and that's not giving the results. Well, the recent systematic review and our own experience shows that quality improvement with skilling has got a largest effect size, more than 50% nearly. So that is something which we need to, pick up as a short-term strategy. Now, if I go to a slightly longer strategy, then we need to pilot test whatever implementation plan we have developed in the 6 months in certain aspirational districts. And I would say the Niti Aayog aspirational districts would be perfect for that, using the PDSA approach. And that's what the quality improvement point of care, quality improvement approach which we use. And then develop contextual recommendations, which may be different for Meghalaya from what they would be there for Rajasthan to Madhya Pradesh. And then develop a national position paper, and then plan a scale up using the TRIP framework, that is translating research into practice to bridge the no-do gap. We have data, we have the knowledge, we have the age-old tools, the training, the supervision, the monitoring, the incentives, disincentives. Now we have to use new tools to fix the age-old problems. So Thomas, that is a suggested implementation plan, which I believe may help. And we should first pilot it at a small level using the QI approach, and then try and scale it up based on the learnings.
Thank you so much. Extremely helpful inputs. Any other words of wisdoms from our discussants?
Yeah. Hi, Thomas. Rajesh this side from Save the Children. You brought up 3 issues. One is data, knowledge, and the third is practice. And I would also like to introduce another term of a policy. The challenge here is that we are all seeing that probably these 3 or 4 components, which are very closely interrelated to each other, they're all sitting in different post institutes in a way, I would say. What I see is that probably the data that is being collected, we all heard it has to be contextualized, it has to be adapted, and that's how you get converted into a knowledge. When you add, you might not have data for everything, but then certain experiences come and then you create it into a knowledge, which then ideally get translated into policies. And then from policies, when you implement, that is where you get the service data. But this is an entirely dynamic process, whereas we see it as a static process. Unless there is a continuity between all these mechanisms, and unfortunately, we don't have such an institutional mechanism in India, just like you have the National Institute of Health and Clinical Care, Care Excellence in UK, or the Norwegian Institute of Public Health. So unless there is an autonomous institute which is working closely with the government agencies and all, and which is linking all of them together, it will be very difficult to make sure that whatever the data that is being created, of course, one is the data at the field level, but also is any data that is being collected making a difference in the policies? Whatever experience we have been seeing is that once a policy is made, I don't know for how many years that policy remains without even we trying to review it after 3 to 5 years, whether that policy has made any difference in the lives of the children and the people at the grassroots level. So unless we have this mechanism, which is continuously being reviewed, and this is a dynamic process, I think it's going to be a little bit challenging. But I also feel that this is the time where probably so many, stakeholders have come in, and especially, with Gates Foundation leading a big change. This can be a game changer for our country, where we have been struggling to have a single mechanism of ensuring continuity between all these three things. Thank you.
Hello.
Thank you. Extremely helpful comments.
Can I?
So,
hello.
Please.
I was thinking, I just very small point to make, Thomas, is that.
Regarding what?
Hello.
Hello. Please, Dr. Rajib, you're on.
Okay. So,
मैडम आप September end में remind कराइएगा.
And please, if you're not speaking, please put yourself on mute because I believe we have a bit of background noise.
Okay, so I would think that if this group can advocate for open nutrition, there are data probably available that are collected by the AWCs that are in the system, which are not being examined by people who are best suited to examine them. And it's not for criticizing the program or criticizing the progress, but to help the best use the data that are being collected. So I would say that it would be a great help to the program if there is an open data policy and if this group can advocate for that. Thank you.
Thank you very much. Any other last comments?
Thomas, I would like to just put in, if you allow.
Please.
Thomas, I think we need to have some new models, and sustainability is an issue. Quality, as somebody has mentioned, the expert comment, I was listening to all these comments. So we need sustainability and new models in order to ensure this. And what we have tested, we feel that involvement of medical colleges with 500 plus medical colleges across the country, and it will be near to the equal to the number of districts in the country in the near future. I think that and community medicine department, which is involved, it will be a mutually beneficial partnership between the community medicine departments of medical colleges as well as the government, this ICDS and health systems. This interface, we think it will be contextual also, and will have sustainability also, the technical expertise also, as well as being a synergistic relationship. So with without developing or adding any extra resources to improve the quality. So this model, I think, should be looked at more, and more scaling up needs to be done. So I think that is what my input is regarding this. Thank you, Thomas.
Thank you, Dr. Amir. Any last words from any of our distinguished participants?
Thomas, we see a couple of raised hands. One is Ramakrishnan Gaur. Maybe we can unmute him or let him speak. And then we have Swapan.
So please go ahead, Ramakrishnan. I'm not sure I know where to see the raised hands, but please go ahead if you can speak. Otherwise, if somebody could unmute him if he is still muted, please do so.
Yeah, I'm allowing Mr. Ramakrishnan to speak. Yeah, Mr. Ramakrishnan, you can speak now.
Hello.
Yes, we can hear you.
Oh, thank you, sir, for giving me a chance. Sir, I am working with the Tata Trust in the field of Uttar Pradesh, Eastern UP. May I use the bilingual?
Please.
Sir, I am working with the ICDS department in the Poshan Abhiyan, and that is the month of Poshan Ma. But I really feel that के जो डाटा हम बात कर रहे हैं, लेकिन डाटा हमको रियल नहीं मिलता है. बेसिकली जो आंगनवाड़ी काम कर रही है, इज नॉट कैपेबल के वो डाटा, उसके पास प्रेशर होता है कि उसको डाटा भर के देना है, बट वो रियल डाटा नहीं होता है. तो जब डाटा सही नहीं पहुंचेगा तो उसके बेसिस पे हम एनालिसिस करके भी क्या कर सकते हैं. मतलब फर्स्टली आई वांट टू से दैट कि हमें कैपेसिटी बिल्डिंग करना होगा, और कैपेसिटी बिल्डिंग जिस लेवल पे हम कर रहे हैं वो कंटिन्यूअस कैपेसिटी बिल्डिंग नहीं है. जस्ट वी प्रोवाइड ट्रेनिंग वन टाइम टू अ ग्राउंड लेवल वर्कर एंड हम सोचते हैं कि काम हो गया, मतलब वो डाटा सही आएगा वहां से, लेकिन एक कोई मॉनिटरिंग नहीं है उसकी. तो डाटा के रिलायबल है, ये तो एक इश्यू है ही। एक सेकंड सर मैं पॉइंट आउट ये करना चाहता था कि जो जिस डाटा के ऊपर हम पॉलिसी फ्रेम कर रहे हैं, अगर वो डाटा सही नहीं होगा तो पॉलिसी सही फ्रेम नहीं होगी। और क्या पॉलिसी जो है वो हर स्टेट के लिए या हर डिस्ट्रिक्ट के लिए एक डिफरेंट नहीं होनी चाहिए? क्या हम डाटा से ज़्यादा कम्युनिकेशन चेंज पर न्यूट्रिशन में अगर हम ज़्यादा अगर फोकस करें तो क्या सर चीज़ें बेहतर होंगी एज ए कंपेरिजन ऑफ वी यूजिंग द कैश or governance dashboard to monitor the activities of Posan Ma and to identify the malnutrition children's, SAM children's. But क्या उससे ज़्यादा अगर हम अवेयरनेस जनरेटिंग ड्राइव्स करते और कुछ ऐसी चीज़ें करते तो दैट इज मोर एप्लीकेबल और मोर बेनिफिट टू द सोसाइटी?
Thomas, I hope you have understood what he said.
Yeah, that's perfect. Thank you so much, Vishal. Any other last points from participants?
So there is one Mr. Santosh Jain Pasi. I'm just allowing him to speak. Dr. Santosh Jain, do you want to say anything?
He's still on mute, Vishal.
Okay. Is it okay now?
Yes. Yes.
Yeah, it is okay. You're audible.
Can you hear me?
Yes, Dr. Santosh, we can hear you.
Okay, I am Dr. Santosh Jain Pasi, former director, Institute of Home Economics, which is a home science college under the Delhi University. What I have to say is that we have a very strong network of home science colleges and agriculture universities, which have a very learned faculty and a number of students and PhD scholars and all who are doing their nutrition and dietetics. So I would like to say, like medical colleges, we should also involve these nutrition and dietetics departments of all home science colleges and agriculture universities where we have that. So we'll get a lot of manpower, and also that will also help in improving the quality of data, because our students are doing lot of work in the field. In fact, my scholars have done PhD work on exclusive breastfeeding, and it has been, a lot of data right from pregnancy onwards we have been collecting, or what is the impact of seasonality on the birth weight of the child and all that. So we have data on height, weight and all for the children. Whatever is the data gathered by the community field workers, I would say that these data from the academic institutions, particularly the PhD and the master's data, that should be able to help in identifying how much is how good is the quality of data collection and where the faults are. So I would suggest that along with medical colleges, let us also induct the services of home science colleges and nutrition and dietetics departments. Thank you.
Thank you so much. So thank you so much for all of the input. So I think I'm going to have to cut it now, and due to time issues. So I let Praveen, if you could summarize, but just before I close, what I want to first thank you for all of the inputs, but more importantly, say that this is the beginning of a conversation. We got all of your suggestions in terms of how to move forward, and we'll definitely make sure that as we enter the design phase of the work, that we're talking with you, and then also for further defining what the next phases of testing and institutionalization would look like. But over from my side, Praveen, if you could wrap up, that would be fantastic. Thank you so much.
Thank you, Thomas. I'll do it. I will try to do it very quickly. So I would, summarize with the quote from Edward Deming, which Dr. Abhay has quoted. Every system is perfectly designed to give you exactly what you are getting today. So this is the key, and this is from father of the quality improvement from Deming. So if we talk about the today's discussion very briefly, and as we will be connecting offline also. So the most important thing, first thing that came out from the discussion is poor quality is a bigger contributor to the mortality, which includes the nutrition services also. Another thing is building quality culture and integrating in institutional functioning is required at this time, at this moment, and this has been came out in the discussion. Another important key area came out as aligning on the common definition and understanding of quality. Quality is important. So this has been discussed and suggested by various speakers in the event. Of course, a skill set is required for frontline providers and managers to improve quality, and skill set is not just only the in-house training as well as the on-site support. Active community participation to bridging the gap is the another focus area which came out from the discussion. Now I come to the measurement and the data. The big component of this discussion was measurement is a key. So improving use of data to improve quality services and improving data quality, both are essential. So it's not all about use of data, but also from the field person from Eastern UP has also talked about data quality is also important. Encourage use of data on quality for nutrition services, not only for the service provider as well as the manager level. So what we see here, I would say the data use is there at the manager level, but it is lacking on the provider's level. So it has been suggested that the data use should be there at both the level. At last but not least, it's high time to improve quality in nutrition services. We should come all together. As a next step, what I learned from all the speaker and participants, like we should all come together for the common understanding of quality in nutrition, development partners, academia, and the government, to work together. Creating sharing and learning platform on quality in nutrition. There are some platform on health, but there are need to create some nutrition related platform also. Formation of core group to work on quality definition, as this is what we Thomas and all has suggested. This is the starting point. So this is the summary and the next step. But at the end, I would like to thank Dr. Alok, Dr. Sanjeev from the foundation, starting dialogue on the prioritization, improving quality in nutrition. As what I remember, like we started the discussions 7-8 months back, and we were supposed to organize such type of workshop maybe in 5-6 months back, but could not due to coronavirus. Dr. Rajesh Mehta has shared principles and practices of improving quality. Thank you so much for joining us. Dr. Abha tells us linkage for data and improving quality. It's very important, and she highlighted the important, and I want to thank Dr. Abha for joining us. Dr. Rajiv, thank you for highlighting the quality data importance for nutrition services, and thank you very much for joining us. I want to thank all the eminent panelists for their advice and comments. We will be contacting you offline for the further steps. I want to thank you all the participants who spent their time, and we hope that this discussion will keep continue to improve the nutrition services. And of course, IP Global Beacon team, especially Novena, for supporting this event as a team. And finally, Thomas and Dr. Seventy for taking lead for this event. Thank you all. Thank you very much.
Thank you. Thank you, everyone.
So, Novena, we can close this event, yes, I think now, and further we will be contacting offline for the participants and the speakers.
To end the meeting. Thank you.
Thank you very much.
Sure, I'm ending it from